Hey there, I'm Rowan, and I'm going to talk about management of shoulder dystocia. Um, so, I would say that I agree with a lot of my mentors in the philosophy that managing a shoulder dystocia does have its across the board like guidelines, but it's also a very case by case situation, and every midwife I think has different strong suits in how they manage a shoulder dystocia. That being said, I am going to use a very recent, like a month old shoulder dystocia case of mine just as like an example of sequence of events in terms of management, but then I'll go into like other scenarios as well for the maneuvers that I didn't use in this case. But I did use two internal maneuvers that I'll be highlighting in this description of management. So, first off, I always have a timer running that's like clearly visible to me and the other attendant that is running from the birth of the head until the birth of the body. And I will always previously ask the other attendant to call times every 30 seconds for me. So that's one tool in place beforehand. I do always have, of course, my resuscitation tray and anti-hemorrhagic drugs nearby, but if I am dealing with a shoulder dystocia, I'm kind of running through multiple things in my mind at one time. One is the physical aspect of actually trying to get the baby out. Number two is assessing where are we in relation to EMS, what was our emergency plan. And number three, communicating with the birther and the assistant about what we need to maximize the best outcome, because with shoulder dystocia, as we know, every minute that passes, we're increasing the risk for a postpartum hemorrhage, and the baby is likely going to need help as well. So I might communicate a couple contractions in, if we still haven't had delivery, to my assistant, please draw up the Pitocin and please bring the resuscitation tray right here. So yeah, and it might be sooner than that. It's kind of a case by case situation depending on what's presenting. But those are my general management rules across the board, and what's running through my mind when I'm managing a dystocia. So let's say in this case, the birther is in the birth tub in like a semi-reclined position like this, birthing, kind of naturally reclining and holding her legs back like this. And I'm here. So we'll flip it like this to say this is her pelvis, and I'm down here kind of supporting her through her pushing. She's making progress. The baby's head is rocking under the pubic bone and then coming down and staying on the perineum, and then she starts to crown, and I'm thinking, that's a good size head, for sure. So crown happens. I kind of apply some gentle guidance to the occiput to kind of keep the occiput flexed. So then the birth of the head comes. And right off the bat, I notice that the baby is turtling slightly. It's kind of hard to tell in this position, but I could see that the ears were what stood out to me as turtling a little bit, and then there was a lack of restitution. So pretty much right away, I said, can we go ahead and please lift your leg up? So hyperextended one leg. I'm watching the stopwatch. About 30 seconds has gone by. And I'm kind of not pulling, but I am kind of applying that gentle axial traction just up and down. So not like this, but just up and down to see to try and feel, instead of just seeing with my eyes what's going on. And during her next push, I definitely felt this little bit of restitution, and then it kind of stopped about a quarter of the way through, and I could literally feel with my hands that the anterior shoulder was jammed. So I said, all right, let's get up and get out of the tub. So she stands up and goes to hands and knees. The baby's kind of partway restituted at this point, not fully. And I'm also checking for like a nuchal cord or a nuchal hand to see if there's anything else obstructing the rest of the baby coming. There was a nuchal cord, but it wasn't tight, so I could just like slip my finger underneath it. So my next move here is going to be assessing simultaneously for which would be better to go for first, to deliver the posterior arm or to go ahead and kind of try a wood screw. And in this case, there was no room for the posterior arm, but I could get into the anterior arm and push that shoulder down, and then the posterior arm comes, right? So pushing the anterior shoulder down this way towards this direction, kind of lifting the baby a little bit. Pushing the anterior shoulder, lifting, a little bit of traction, then back down, gave me enough room to deliver this posterior shoulder, okay? So those two internal maneuvers, wood screw and the posterior shoulder. And then from that point, it was kind of rocking, not pulling on the head, and not hooking the arms to avoid a brachial plexus injury, but just kind of rocking the shoulders. Let's hold this like this. Back and forth to then deliver the baby the rest of the way. Baby was pretty floppy, and then we got her flipped back, put the baby on her chest. So that was that situation, and most of the time I personally have found in my own management that what works well is doing the wood screw initially. Just to go ahead and try and address that anterior shoulder if it's possible. But other options would be getting her out down onto the ground into McRoberts to apply suprapubic pressure to the anterior shoulder, like so. I would probably have the assistant applying the suprapubic pressure to this anterior shoulder, and then I would be down here kind of go ahead and doing that wood screw while the shoulder is being released to deliver the baby. And what else? Oh, I personally have never had to go for breaking a clavicle. Knock on wood. Really hope that I don't have to anytime soon. But obviously, that's an aspect of shoulder dystocia management that I would like to talk about. And what else? I think that's about it. But I will say also, like in the algorithm that I submitted, we're gonna do a combination of position changes and the maneuvers that I just spoke about in 30 to 60 second increments until delivery. And no more than that on each maneuver in each position. So we can do a combination of these maneuvers in various positions, but except suprapubic pressure, you kind of have to have the person like lithotomy McRoberts in order to do that. So yeah, and then one thing I've learned too in my management protocols that's really valuable is tapping each other in and out, the midwives. At first, as a student, I felt really down on myself when I had to tap my preceptor in when I couldn't get the baby out. But it's not about me. It's totally normal, and it's actually, I learned, a really great thing to do in clinical practice, to not exhaust yourself, and like physically and mentally, because after about a minute, you might be getting really like just not mentally clear on what you'd like to do next. So stepping back, watching what the other midwife is doing will give you a minute to rest your body. It's really hard on your body managing a shoulder dystocia and doing maneuvers, and also see from an outside perspective when you're gonna get, if you're gonna get tapped back in, what your next move is gonna be. And I know it might seem silly to point out, but as far as managing shoulder dystocia, it is so important to breathe as the midwife managing the dystocia. I have seen midwives almost pass out, forgetting to breathe during this process. So even if we can help each other I know that seems like a silly priority to have, but to me it's to be taken seriously, because if you're passed out or you're hurt yourself so bad in the process, or you're just panicking so badly and not breathing, you are no help at all. So breathing in the process, it just takes 1 second to just take a breath, keep going, gather yourself so that you're strong enough to help facilitate the birth. I think that's all I wanted to talk about today with the management of shoulder dystocia. So thank you so much for listening.